Okay, so when you're pregnant, you get a ton of new terms thrown at you, right? And some of them can sound pretty intense. One of those is polyhydramnios. Sounds complicated, I know, but today we're going to break it all down and make it super clear. Let's dive in.
So here's the game plan. We'll kick things off with what this thing actually is. Then we'll get into the why, like why does it happen and how doctors figure it out. We'll touch on the potential complications, and then, super important, we'll walk through the management plan before wrapping it all up with the key things you need to remember.
All right, let's get right to it. Section 1. What in the world is polyhydramnios? So we all know amniotic fluid is a big deal for a developing baby, right? It's like this perfect little cushion. It helps the lungs develop. It does a ton. But is it possible to have too much of a good thing? Well, that's exactly where this term comes in. Polyhydramnios. That's just the fancy medical term for when there's way too much amniotic fluid hanging out around the baby. But to really get what excessive means, we gotta know what's normal first. See, the amount of fluid changes throughout pregnancy, but it usually hits its peak at about 800 to 1,000 milliliters, somewhere around 28 to 32 weeks. Okay, so here's the kicker. With polyhydramnios, we are not talking about just a little extra fluid. The line is usually drawn at over 2,000 milliliters. Yeah, that's double the normal peak amount. So when they say excessive, they really mean it. Okay, so now we know what it is. The next big question is why? Why does this happen? What's going on to cause this fluid imbalance? Okay, I love this slide because it makes it so easy to understand. Think about the amniotic fluid like a bathroom sink. You've got the faucet running and the drain is open. It's a balanced system, right? The baby is constantly swallowing the fluid, that's the drain, and then, peeing it out, which is part of the faucet. So with polyhydramnios, something's off with that balance. Either the drain is clogged, meaning the baby isn't swallowing enough, or the faucet is cranked wide open, meaning there's way too much fluid being produced. Now, to keep all the possible causes straight, there's this really handy mnemonic doctors use. It's 3 M's plus 3 F's plus placenta. Let's unpack that. All right, so the M's, that's for maternal causes. The big one here is maternal diabetes, but also things like Rh incompatibility. The F's, that's for fetal causes. This can be stuff that makes it hard for the baby to swallow, like a blockage in their esophagus, or stuff that makes them produce more urine, like fetal anemia, or what's called twin-to-twin transfusion syndrome. And then last but not least, you've got the placenta. Sometimes a rare tumor on the placenta called a chorioangioma can be the culprit. Okay, so we just went through all those potential causes, right? But check this out. This is probably the most surprising thing you'll hear today. For about 60% of cases, the cause is what's called idiopathic, which is basically the medical way of saying we actually have no idea why this is happening. Isn't that wild? The vast majority of the time, there's no clear-cut reason. So if this is going on, how would anyone even know? That brings us to our next section, signs and diagnosis. What do you look for? Now, it's really useful to know the difference between symptoms, that's what you might feel yourself, and signs, which is what a doctor or midwife would find. So for symptoms, you might feel really breathless or notice your belly is getting huge fast. The signs a doctor looks for are a little different. They might find that your uterus is measuring way bigger than it should be for that point in the pregnancy, or that your abdomen feels really tense. They might even have a hard time hearing the baby's heartbeat because it sounds so far away through all that extra fluid. But to really know for sure, to get that definitive diagnosis, there's one tool that's the absolute gold standard, and that's the ultrasound. It lets the doctors literally see and measure the fluid. So what are they looking for on that ultrasound screen? Well, they have two main ways to measure the fluid. The first one is called the Amniotic Fluid Index, or AFI for short. Basically, they divide the uterus into 4 sections, measure the biggest pocket of fluid in each one, and then add them all up. If that number is over 24 or 25 centimeters, bingo, that's polyhydramnios. Or they can use another method called the single deepest pocket, or SDP. And that's just what it sounds like. They find the one single deepest pool of fluid. If it's more than 8 centimeters deep, that also counts as a diagnosis. Okay, so getting a diagnosis like this can definitely feel a little scary, and that's totally normal. So it's really important we talk about the potential risks in a clear way. Let's take a look at the possible complications. We can basically split the risks into 2 camps, risks for the mom and risks for the baby. For the mother, because the uterus is stretched out so much, there's a higher chance of things like preterm labor or the placenta detaching too early, that's called a placental abruption, and also a higher risk of heavy bleeding after the birth. For the baby, the big risks are being born prematurely and also something called a cord prolapse. That's a rare but really serious situation where the umbilical cord can actually slip down before the baby during delivery.
So we've talked about the risks, but I want to be super clear about this next part. The good news is, doctors have a very clear plan for how to manage this. So let's get into our final big section, the management plan and how it's treated. The very first thing doctors do is figure out how severe the condition is. They classify it as mild, moderate, or severe, and they do that using that AFI measurement we just talked about. This is super important because it helps them decide what the next steps should be. So the overall game plan is pretty logical. For really mild cases, it might just be a watch and wait situation, with more frequent checkups. But for more serious cases, the plan can move on to include medical treatments, sometimes therapeutic procedures, and always a very careful plan for delivery. The path they take really depends on the severity, what's causing it, and of course, how far along the pregnancy is. Now, if things are more moderate or severe and an intervention is needed, there are a couple of main options on the table. One is a medication called indomethacin. It can actually help reduce how much urine the baby produces, so it's like turning that faucet down a little. Another option is something called a therapeutic amniocentesis. That's where they use a needle to carefully draw out some of that extra fluid, which can really relieve the pressure and the symptoms.
Whew, we have covered a ton of information. So let's wrap this up by boiling it all down to the key takeaways, the most important things to remember.
All right, quick summary. What did we learn? 1. Polyhydramnios is just a fancy term for too much amniotic fluid, and it's diagnosed using an ultrasound. 2. This is the wild one. While there are known causes, over half the time, the cause is idiopathic or unknown. 3. How it's managed is all about monitoring, trying to treat any underlying cause, and making the mom more comfortable. And finally, and this is the most important part, while there are risks, there is absolutely a clear plan for monitoring and care.
And that leaves us with one final, really interesting thought. If up to 60% of cases have no known cause, what kind of research, what breakthroughs might finally unlock the mystery of idiopathic polyhydramnios? It's a huge question for the future of medicine. Thanks so much for joining me for this explainer.